this is Teresa and Aubrey with the Education Department. Today we're going to talk about patients with chest tubes and chest tube drainage devices, how to care for them, what that process looks like, and how to manage specifically the Atrium Dry Seal drainage device. Patients are typically going to come out of the operating room with a chest tube, or it may be placed at the bedside, either planned or emergently. So you will note some of the supplies that you'll have to have at the bedside. You're going to need some petrolatum or Xeroform dressing. You're going to need gauze sponges, Mefix tape, suction tubing. You'll need, of course, your Atrium Oasis dry suction. This happens to be a dual collection. Typically you'll see single collection. The Trocar, which actually has the chest tube in it, this is what actually goes into the patient. You'll need a suction regulator, a suction setup, and suction tubing. When you open up your drainage system, you'll note that it's wrapped in blue. It is not sterile, it's clean, but needs to be managed at one point in a sterile fashion, and we'll talk about that. On the back of the Atrium device, if you forget the steps, it very clearly will show you the steps in setting up the Atrium device. On the back, you'll see this little container. It's filled with sterile water. It's actually located right here. You just pull it off. Think blue to blue, connect it, and empty all of the sterile water into the Atrium and connect your suction. That water fill will fill up exactly what you need. You don't have to add any water, and you don't have to remove any water. Once this is connected and to suction, the E is a bellows, and the bellows will expand to what's called the delta mark, that little triangle there, and that's what indicates that you have full suction and that it is working appropriately. So your provider will place this at the bedside, and they will ask you to hand them the end of the chest tube collection tubing. This is the chest tube itself. These are disconnected. At the tip of this is sterile, and this is what you will hold out for the provider to connect into. These are always sutured in place. And when the provider is done and we've connected, the provider will place clear tape vertically on both sides, and this allows us to evaluate at the connection if there is an occlusion, perhaps with a blood clot. The first dressing is typically placed by our provider, although they may ask your assistance with it. Dressings are changed typically daily. They can also be changed PRN for soiling, or as often as the provider indicates. Very commonly, that first dressing is not changed immediately, or it may even be changed by your surgeon the very first time. You'll just need to check your orders, and your orders for your suction and for the dressing will be either in the provider orders, in the chest tube management, or it may be in nursing communication orders. So just some quick tips about taking care of your atrium. What happens if your atrium falls over? If your atrium falls over, this is not to be a worry or concern. You merely return it upright, and then you can tip it to get whatever has spilled into the other columns back into the main column. You won't be able to get it all back in there, and that's okay. And then you would mark exactly where it's at so measurement can occur from that point. The output on your chest tube should be documented at least every 4 hours on the med-surg unit and every hour in critical care. You'll need to add the avatar for the chest tube on your patient in Epic. Once you add the avatar, it will automatically link it to the in and out flow sheet, where not only you will be able to document your output, you will also be able to document your assessment. You should be looking at your site. Is it clean? Is it dry? Is it intact? Is my dressing clean, dry, and intact? Did I have to change it? Is there any signs of redness or infection? Those are the things that we're going to want to look at. We're going to document I&O in that in and out section, and it's never acceptable to just leave a blank entry. If there's no output for that current time period, you need to put a 0 so that it will calculate correctly. I'll talk a little bit about air leak management. We have a little bit of an air leak intermittently. That is okay. It's actually quite common and normal, and we're waiting for that to resolve, and that's a lot of the reason why we've got the chest tube in place to begin with. However, if you see a continuous air leak, which means I'd see a lot of agitation and movement there, that is an indication that I have an ongoing and continuous air leak. The first thing that I want to do if I do note that there is an air leak is I want to check all the connections on the tubing. So I want to check here, make sure that this hasn't gotten loose or gotten disconnected. You want to check the entire lumen of the chest tube all the way to the entrance into the chest. You don't have to remove the dressing at that point, but you will want to look for any kind of holes, and if you can't resolve it, you would strip it all the way down under the dressing and make sure none of those holes or little lumens at the end of the chest tube, which is how the drainage enters into the system, is outside of the chest, because that would create a continuous air leak. If none of these measures will resolve it, the next step would be to call the provider, but there's one last place to check, and that's where the atrium tubing actually connects to the atrium device. So this is one last place where you want to check and make sure that you don't have a loose connection. All right, how to manage an emergency. What emergency do you ask? What if the chest tube falls out? Well, the chest tube falling out is a medical emergency. We need to manage it immediately. That's why we keep dressing supplies at the bedside, which is going to include Vaseline, petrolatum, Zeraform, an occlusive petrolatum embedded dressing. This will help stick to the wall and help prevent air from being pulled in that hole in their chest. You also need 4x4s, and you need Me-Fix tape. You need to create a 3-sided dressing, only 3 sides, not the 4th side. That allows when the patient to breathe in, the chest dressing will collapse against the chest wall and prevent further air from being pulled into the chest. And as they're exhaling, that 4th open area allows the air to come back out like a flap valve. Finally, beyond the immediate placement of the dressing, we have got to call the provider right away and let them know what happened, because they are going to have to come and assess the patient at the bedside to determine what may need to be done next. Some of the things that we can do to also help prevent pneumothorax is to check our connections. This should be done every shift. You want to check your connection at the patient, check your connections from the chest tube to the drainage tubing. And again, just like I noted before, check your connection where it connects to the patient. And finally, we're going to check the connection at the suction tubing and make sure that that's attached. Quick note here, suction regulator on the wall is where it's set for 80 milligrams mercury and continuous. Has to be continuous, cannot be intermittent. So we're going to set that for 80, but we'll control the level of suction at the atrium device itself. The atrium device is automatically set for 20 millimeters of mercury. You can see that. To adjust that, you just come to the side and you can adjust it with the dial. Otherwise, it's going to be set for 20, and typically the patient's order is going to be for 20, but you need to check your order because it may be less. If it's still leaking and we're still having an issue where our provider may end up having to place a second chest tube, if he's going to or she is going to place a second chest tube, you want to go ahead and have another chest tube set up and the drainage, all of your supplies for another whole setup at the bedside. You will see titling. Titling is normal. This little ball will come up and down. That is normal. That occurs with inhalation and exhalation. That shows you that the device is working correctly. What do you do if your device is full? Well, if it's full, we're gonna change it out. So you're gonna go ahead and get another drainage device. It needs to be the same, single to single or double to double. This is the one and only time you will ever clamp your chest tube in order to change out the device. So when we're doing the change, you would clamp it, disconnect it, and then just change to your new device. Then we'll say, this is my new device, connect it. Most importantly, you must unclamp. If you do not unclamp this, all of this back pressure to the chest tube and to the lung will create a pneumothorax, as we've already noted, could be potentially life-threatening. We do just a couple of things. We do not take patients off suction. They have to have an order to be on water seal. We'll talk a little bit more about that, but they stay on suction until there's an order for them not to be on suction. And again, you have to check your orders. If the patient tubing doesn't allow it to reach to the bathroom, you need to use a bedpan or a bedside commode, urinal, whatever you need to do at the bedside, but we don't ever extend this tubing because it will interfere with the level of suction that's provided to the patient. When we go to discharge or discontinue a chest tube, the dressing again is the same. It's going to be a petrolatum dressing. It's going to be 4x4s, and it doesn't need to be 3-sided then, because this is the dressing that they'll go home with, and the provider has already determined that the need for the chest tube has been resolved. And then of course you're going to cover it with MEFIX. Typically these are kept in place for 48 to 72 hours after the chest tube is removed. Some final tips for your patient: if you're traveling with your patient, going to chest x-ray, MRI, and these are MRI compatible, you would disconnect from, not that one, gonna disconnect from your suction tubing. You would leave this obviously in the room. This travels with the patient below the level of the chest. For the purposes of this discussion and demonstration, you see me having it up on the bed, but this is not where we would have it. There are clip hangers, and this attaches to the rail of the bed so that you can travel. All right, some final notes. Let's talk about weaning. The whole point of this is to get this out of the patient, right? So your provider's gonna have some weaning parameters and orders. Typically what they'll do is they'll place the patient on, sometimes they'll decrease the suction like to 10 centimeters, but often they'll just go straight to a water seal. And what a water seal means is this is all still in place, but it's not connected to suction, so that this, the water seal, is the only thing that's managing the pressure in the tubing line. So when this is on, we're to suction. When the provider wants to wean and water seal, this is removed. That's the only thing that has to happen. Of course, this is going to be on the floor. As the provider is weaning, of course, we want to be assessing our patient and make sure they're tolerating it and they're not becoming tachypnic or tachycardic or restless, short of breath, any of those signs that they may have some kind of increasing dyspnea or work of breathing, which could be, again, a pneumothorax, which we've already discussed. Weaning, when the patient's weaning to water seal, of course, this is again on the floor. All of this suction setup has to be discarded. Otherwise, another one of your teammates could come in your room and think that somebody forgot to hook them up, or it inadvertently got disconnected, and they could reconnect it, and that would then interrupt or even ruin the weaning trial. That's all we have about chest tube management, use of the Atrium Dry chest tube drainage system. Thank you very much for your time, and see you in the pod.